To start that off, let me introduce our first speaker, Dr. Stephen Cha, who is the Chief Medical Officer for the Center for Medicaid and CHIP Services at the U.S. Centers for Medicare and Medicaid Services. So that agency oversees the federal Medicare program as well as the state-run Medicaid program and the CHIP program, Children's Health Insurance Program. They provide coverage for more than 60 million. Almost 1 in 5 Americans are in these programs. And Dr. Cha, in addition to the work he does with that area of the budget, also promotes health transformation and modernization for Medicaid and CHIP, which are going through changes and will continue to in the future. Before joining CMS, Dr. Cha was a senior professional staff member for the Committee on Energy and Commerce in the House of Representatives, working for Chairman Henry Waxman, who is one of the leaders and, frankly, in my opinion, one of the heroes of the AIDS epidemic response by the federal government. And he worked for him as they shaped the Healthcare Reform Act that was passed in 2010. So without further ado, Steve.
Introduction. So my name is Steve Cha. I'm the Chief Medical Officer for the Center on Medicaid and CHIP Services. It's just a fantastic opportunity to be able to be here and speaking with all of you. I think this is a critical time to take a moment and think about how we're approaching some of these 2014 challenges and what we can do now, because now is the time to think about it, not in 2014 and 2015. So I especially appreciate the forward-looking nature of your leaders to invite us to speak to you and begin this conversation now rather than later. I'm also a practicing primary care doc. I see patients every Tuesday evening. That's been part of what I've been doing since I got to DC, working on the Hill, even through health reform, and I think it's provided important insights for me in terms of how we think about health policy, but in addition, I still consider myself a primary care clinician by heart, and that's who I am. The other thing to mention is that this position is a new position at the Center on Medicaid and CHIP Services, and I think that's relevant from this perspective of a new direction that I think we're trying to accelerate our progress towards thinking how we at the Center on Medicaid and CHIP Services can be better and more forward-leaning partners, how we can better match up and promote what we know as good evidence-based policies out there. That, at the end of the day, when I think about my job, I work on delivery system reform, I look on quality, I work on a lot of discrete issues, but the question that I sort of think about every day and I go home thinking about every night is, are our policies and procedures supporting the best evidence-based practices that are out there? And if not, what can we do better? Or if there's obstacles, how can we reduce those obstacles? That's my challenge, and tremendously been gratified to see that our leadership, both Cindy and at the department and all the way up, have been tremendously supportive of this idea and this mission of trying to think about that job at CM, at the Center of Medicaid and CHIP. In particular, transition for people with AIDS and HIV to full insurance coverage is a critical topic. And I think there's a lot of things to unpack here in terms of thinking about what this means as we move forward. I wanted to focus maybe in the talk in three ways. First, talk a little bit about what happened in California, and some of you know a little bit of what happened there, some of our lessons from that, and then want to have some time to engage with you all about how we move forward from those lessons. So starting with California, I think many of you may have heard about what happened there. There was, I think someone forwarded me an article in your magazine, The HIV Specialist, by Ann Donnelly and Courtney Mulhern Pearson, I think, who are here. I thought it was a fabulous summary of what the challenges are and how we need to be thinking about this. But just to give you the quick snapshot, in November 2010, California took the feds up on our option under ACA to begin expansion early, essentially, and expanded to significant numbers of new people. And there's no question that this was a good, positive thing that we wanted to figure out how we could best support. There's no question that expanding coverage is a helpful thing. I think because Ryan White can only be the payer of last resort, we realized sometime down that road that people were going to be facing some abrupt transitions of care, and I think there were a lot of concerns, rightly raised, quite frankly, in terms of how that transition was going to unfold. CMS has been working with the state, the county, with our HRSA partners, and with public hospitals to revise that plan in a way that, frankly, we didn't quite collaborate on before that plan was written. And we certainly had collaborations with all those agencies, but really unpacking this specific question to really think about how this works, to create an amendment to their 1115 amendment. And I should back up. 1115 amendments are waivers that we offer to states to allow them to restructure their Medicaid program, so long as it's serving the purposes of the program and it's budget neutral. And so California took us up on our opportunity and the opportunity to expand to significant new numbers of beneficiaries. So we worked with them on this amendment, and the amendment will ensure that people with HIV make as smooth a transition as possible from their Ryan White providers to what we're calling these low-income health plans, which are the county-based plans, and that transition happens without a loss of core medical or other critical services. And part of the way that we're doing that is it creates a new category of incentive payments for providers for HIV activities to address the issues of access, continuity of care, and comprehensiveness of services. Medical home being the most obvious piece of how some of those incentive payments are going to flow. Trying to work with HRSA to ensure that the same standards that now apply to Ryan White providers also apply in the context of this program. So this is where some of these lessons that we realized after the fact, and we're trying to adjust that plan as we go forward. So what are some lessons? And I'm curious for the policy panel, since a lot of those people have looked quite closely at this plan as well, to hear some of their reflections as well. But from our perspective, I guess two pieces to start out with in terms of lessons learned. One, regarding the transition to full coverage, there's no question in my mind as a physician who cares for patients that having coverage, all other things being equal, is better than not having coverage. There's just no question about that. Our patients are better served when they don't have to face all the challenges that we know that we've, and I know many of you have struggled with. And that's a good thing. And then putting on my hat in terms of my Hill days, I remember the yearly travails of trying to think about Ryan White funding and the issues about ADAP every year and thinking and worrying about that. It was a constant concern from us at the policy level as well in terms of how we'd address that. So from the first perspective, as much as Ryan White has been a tremendous success, there's no question that having coverage is better than not having coverage. The second point to acknowledge, in particular in the context here, is that there's also no question that Ryan White has been an invaluable support and provides some incredible ranges of services that standard insurers are not picking up as well, and includes incredible components, incredible strengths to that program that we need to think about. So this is, in my mind, an opportunity. It's a real opportunity to pull down and draw and create that base of coverage provided by Medicaid, and then think about how Ryan White can interface with there, and learn the lessons about what Ryan White has done well, learn the lessons about what coverage has provided well, to think about moving forward to create a more cohesive and comprehensive system for our patients than ever before. This is the real opportunity. But this opportunity is not going to happen, and I think this is one of the real lessons, without some significant work and collaboration. So how do we move forward? And I would identify three specific areas to think about within the sort of moving forward category. The first is collaborations at a national level. Second is collaborations at a local level. And the third is how we think about delivery reform. So collaborations at a national level, we need to do a better job within HHS, within the administration, about how we can coordinate and ensure that we are presenting a unified front in terms of how we're moving forward. I'm getting involved in some of these now. As I said, I'm new to the agency, but jumping right in, I think it's a real opportunity from my perspective to think about how we can unpack some of these. The Presidential Advisory Council on HIV and AIDS, some of you may be familiar with. This is a council specifically convened to try and address some of these issues. I've just started joining in on those meetings and plan to engage more fully as time goes on. But we need to think about at a very high level how we're thinking about this. The second piece is to unpack that even further, some of the staff level context between HRSA and CMS. When we think about how we can specifically unpack some of the details, it may not happen in these blue ribbon panels. It may be just getting the work done and being more effective in that fashion. And from that standpoint, I can point to the work that we engaged on with this HIV amendment in terms of working with our HRSA colleagues at a very low, I shouldn't say medium to the analyst level staff, working together hand in hand to think about how do you unpack these problems. That's what it's really going to take to unpack some of these solutions at the national level. So you need collaborations at the national level, both at the high level in terms of how we're thinking about this from the leadership perspective, but also how we're thinking about this when we actually unfold the policies from the national level. That's not enough, though, and I think that's only going to be a small piece of the picture. The real key is going to be collaborations at the local level. I can't emphasize that enough, and this is not a punt. This is not a way of saying we're not going to be engaged as well. We will be. I'm telling you right now, we're going to be working to try and collaborate and coordinate as best we can, but this cannot happen without that local level work to ensure that the current providers and whatever system is transitioning in are all at the table thinking about how this new system is going to look. The state Medicaid agencies, the state AIDS agencies all have to be there together, advocates and providers, and to think about a transition plan that reflects the needs and strengths and problems and issues of that particular state and area. And I think under that, I think needing to ensure that whether it's the MCOs or in this case the low-income health plans or whatever that system may be that's developing in that particular state to expand coverage, to ensure that that's capturing the providers that need to be served there included, and to be ensuring that everything from the benefit package to the formulary is addressing the needs of people with HIV and AIDS. That's all going to happen primarily at the state and local level. So we will continue to be engaged, continue to try and do our best to coordinate from the national level, but it's incumbent upon folks like yourselves to really get involved with this process to ensure that this reflects the needs of your patients and the people who need these services the most. So that's collaborations at the national level and the local level. The third piece, and I think this folds across both of these, what can we do to better support some of the lessons about delivery system reforms that we know can be helpful to our patients? And that's everything from within Medicaid under the ACA, we have a new provision called the Health Homes. This is a provision that provides enhanced services, an enhanced package of services, care coordination, and those types of services for people under Medicaid program with a 90% match for 2 years. And so we, the feds, are going to pick up most of the cost for that, for these health homes for a significant amount of time, recognizing that at the outset in the early years, a lot of this is infrastructure costs. It's hard to absorb those costs at the local level. We're saying we're going to invest our federal dollars and pay for those for 90% of those costs for 2 years, and then transitioning into, once that infrastructure is built up, to the regular match rate. I think there's a real opportunity to think about designing health homes to address people with HIV and AIDS in terms of how they can best fit those needs. The second piece is, again, part of this whole agenda that we have at the Center on Medicaid in terms of trying to, what we're talking about is Medicaid moving forward, this idea that we're trying to accelerate our pathways towards change, accelerate our orientedness towards evidence-based practices. We released 2 letters 2 weeks ago, and I think we're calling integrated care models. And these were letters to state Medicaid directors saying that you have new flexibilities under your authorities that you may not have been aware about to design what we're calling integrated care models, delivery system reforms, whether it's ACOs, shared savings, medical homes, whatever you want to call it, systems that are designed more towards patient-centered, accountable care. And we're expressing new flexibilities that the state has to do these without a cumbersome administrative process. We're really excited about this, and we're excited to work with states to think about how to implement some of these integrated care models. But regardless of whether it's the Health Home Authority under the ACA or the integrated care models that we just released last week, I think the bottom line from Medicaid is that it's a complex program, certainly, but we have a number of authorities. Medicaid, unlike other programs out there, has an extraordinary amount of flexibility to work with, so long as states and providers and stakeholders want to go in a certain direction. More often than not, then we can find some way, and we are trying to be more creative than ever about how pathways to ensure that we get there as long as we're focusing on the needs of the patient. I think our focus and what we talk about is something that many of you heard about in terms of the three-part aim. That is things that we know, and we know there's a set of interventions out there that we know can improve the experience of care, can improve the health of populations, and reduce the cost of care. That's where the sweet spot is, and there's a tremendous set of opportunities, particularly in a population like people with HIV and AIDS, to think about how we can do our jobs better, and what it would take from Medicaid to get that job better. We're here to listen to the ideas that are coming to us from the states and think about how we can better support the best evidence-based practices out there. The third piece, of course, is that interface with Ryan White programs. We know that some of the Ryan White providers have been doing this with the Ryan White support for years already. So to the degree we can avoid reinventing the wheel, obviously that's better. And so to the degree that we can either think about how that support will move going forward or think about keeping those same systems and thinking about new ways to financially support those, all that is engaged in a conversation primarily predicated not at the national level. Again, what's happening at the state and local level, how that Medicaid program is designed, how that state AIDS program is designed, and what's happening at that state level, and how we can best from the federal level do our job to support what you're all doing out in the field. So I guess the question that I hope I would hear more from you, and the reason that I would want to listen, is how can we be more supportive? What can we be doing? What should we be thinking about? Again, I think this is the right time to be having this question. California went first, and I think provided some important object lessons for us. It was incredibly useful for the rest of the country, frankly, to see what happened there and to learn from that experience about this opportunity we have. And I really think it's an incredible opportunity that we have, and how we can walk down that opportunity and maximize the potential for improving the systems of care out there. I have no doubt in my mind that come 2014, when the Medicaid expansion hits, that this is just a tremendous way to improve care for the populations that we serve. There's no doubt in my mind about it, but we have to do this right. We have to think about drawing the best from the new opportunities and pulling the best from the worlds that exist now, and how can we blend that together. I know that's possible. I also know that work like that is hard sometimes, and what I'm telling you that from our perspective, we're ready to roll up our sleeves to work with you, and we're hoping that you're ready to work in your local communities to do the same. But I wish I could tell you that this is going to be a cakewalk, but I don't think it will be. But I do think that there's tremendous amount of benefits for providers and patients at the end of the road. This is a situation where we can't pass up this opportunity. There's just such an amazing chance to improve the lives of the people we serve, and I hope to work with many of you to make that happen. Thanks for your time.
So Dr. Cha has some time for a few questions. If folks can go to the microphone and start off just by identifying yourself so that we know who you are, and ask whatever questions you'd like. Thank you. Yes, ma'am.
Hello, thank you. Dr. Debbie Holmes, Miami AIDS Healthcare Foundation. Big question is, how can we achieve these challenges when your governor doesn't even want to expand the program? Already in 9 states, the governors have decided that they don't want to expand the program, and I know that the feds are supposedly picking up, I think it's 90% of the cost for the first 3 years. I mean, and here we are in Miami, which now has the highest rate for any city of HIV in the country per 100,000, and it's just, yeah, you put pressure on the Congress people and work with your politicians, but I think there should be some type of mandate to cover these people and get the word across. If you get people into care, maybe we could get control of the epidemic.
I mean, I couldn't agree with you more. I think that the Secretary wrote to the governors on July 10th, and that letter is available, I'm sure, online. If you just Google HHS and July 10th governors. And I think she summed up what we're trying to say the best, which is it's time to move forward. There are multiple ways that we're working with states in their efforts to try and expand. We are covering 100% of the costs of this expansion population from 2014 to 2016, 90% of the costs thereafter. We're frankly very hopeful that all states will eventually take advantage of this opportunity, but a lot of governors are saying things now. I don't think any of this is sort of written in stone yet, and I encourage you to continue those conversations in your own localities. I think we're doing what we can from the federal level in the context of the Supreme Court decision to send as strong signals as we can. Is we're ready and willing and hoping that all of you want to work with us on this, because we think this is a fantastic opportunity for patients, but frankly also a fantastic opportunity for state budget coffers as well, which is, I know, ultimately what a lot of folks are facing. When you think about the uncompensated care coming through hospitals, and the fact that states are paying for many of these folks one way or another, I mean, you all know these arguments, and we stand ready and willing to work, but there is no mandate that we can issue from on high about that. All we can say is continue to express our willingness to work with everyone in terms of how this can unfold. One added piece on that front, which is that I did work on the Hill for 6 years, and particularly when I left, it was, I would say, a relatively unpleasant conversation at times. And I think one of the most refreshing pieces about coming over to CMS, despite my fears about some of this and some of the frontline and headlines about Medicaid, ULC, I can tell you that in every state, including your own, there are fantastic people working to make good things happen at every level, and every red state or blue, and at the directive governor or within the context of broad outlines. There's great stuff happening all over the country, and so I think that obviously the Medicaid expansion is better, but I think that there's still opportunities no matter what happens moving forward. But I feel confident that governors will see this eventually, and I think providers will probably help in that conversation at that state level to ensure that everyone sees what a good deal this is. So I remain confident, but we'll see. We get dealt the cards we have.
Dr. Cha, I'm Ian Gilson from Medical College of Wisconsin in Milwaukee. And first of all, I don't know whether to offer congratulations or my sympathies with taking on one of the most challenging jobs in the history of American medicine, but best of luck.
Thank you.
But as we all know, probably the biggest challenge in HIV care is adherence. The biggest issue in adherence is mental health. And the biggest issue in mental health, in my mind, is how can we deliver it in an effective, evidence-based way in primary care. And the evidence is accumulating that the way to do it is with teams, including integrated mental health professionals with primary care doctors and nurses. And frankly, we can't do this right now in most Medicaid systems. There are models. The VA, for instance, is one model where it seems to be done. And I wonder if you are developing a Medicaid medical home, are you thinking about a strong mental health component with built-in funds so that mental health people will actually take these jobs and do the work? Because I think we'll get better outcomes and it'll ultimately be cost effective if the adherence rates goes up as they do when you treat depression. But how do you envision the integration of mental health? Right now in Wisconsin, at least, I don't see it happening.
So this is a great question. I should also say my Tuesday evening clinic is in a substance abuse transitional shelter for homeless guys who have been in a substance abuse program, and this is their transitional housing before they launch, and so there for 6 months to a year at a time. I see this every Tuesday night in terms of and I should say I practice in a non-integrated system where I try to call the psychiatrist to figure out clozapine issues, things like that. That's obviously the most basic, but everything in terms of the patient will tell me something that I know the psychiatrist needs to know, some new element of suicidal activity or something like that. And I would say less than half the time I make that connection, even though it's just hard. And I don't blame any of the providers on the outside. It's hard, but it's also not good care. So what are we doing from the federal level? I would say there are a lot of things happening, which is good. So when I talk about these delivery system reforms, when I talk about the various ways we can support them, I would say the majority, I don't know about the majority, but I would say a good chunk, if not the majority, pretty close to the majority, of the health home proposals we've gotten so far have been behavioral health and orientation. It's recognizing, and again, part of the state's interest here is that these are also their cost driver populations, right? And so there's a great argument to be made to the states to say, these guys are costing you a lot, and we're not doing a great job of taking care of them. So this is, again, when I talk about triple aim, great opportunity to unpack this. So a lot of those are oriented towards the health homes. That 90% match I was talking about is oriented towards behavioral health population. The second piece is that within a lot of these waivers, these restructuring of funds that I'm talking about. I'm thinking about Oregon right now. A key piece of their restructuring in terms of their delivery system reform was, in fact, reorienting and integrating the primary care and behavioral health, actually physically in their model, putting them in the same place. And we couldn't be more supportive of those sorts of ideas. The challenge here. So I would say from our perspective, again, I think numbers of authorities, whether it's Health Home, whether it's a waiver, whether it's, again, these ICM kinds of things I was talking to you about, a number of ways that we'd be delighted to support these efforts. What I've heard about in the challenges is that behavioral health and substance abuse is talk about silos. You have division of Department of Health, you have sometimes Department of Medicaid in a different place, and sometimes you have departments of mental health services in yet a third place, and these three groups not talking and thinking about the opportunities to align here. So I think that's a challenge, and I think it's incumbent upon, again, folks like yourself saying, here's a great opportunity, here's a great model of care, and trying to think about importing that or importing an element of that to your state and thinking about pitching it to the right folks. It's hard work, though. The third thing I'll mention, recognizing that, is something that just went live last week, which is the state innovations models. This is a grant from the Centers for Medicare and Medicaid Innovation. We've been working with them for months to unroll this, and we're very pleased this is getting out there. This is specifically a grant opportunity for governors to think about large-scale reforms that they want to execute from the governor's level. So I think this is a great opportunity to think about when you think about crossing silos. It's an opportunity for governor to say, okay, well, my 3 silos here, I'm going to use this money that CMS is offering to maybe think about, let's get all our people in the same playpen and get going on some of this sort of stuff. I think substance abuse and mental health. I think about maternal child health. I think about things that are divided, and HIV. I think about things that are often divided across silos at the state level. This is a great opportunity where we're putting money on the table for a governor to say, we want to help you get there. So we have 5 states, 5 awards that are available for 5 states for relatively large-scale projects, and then about, I think, 20 grants available for small, more sort of design, planning and design grants possible for some of those states. So I would say from our perspective, we're trying to do whatever we can to really push and move forward on that. We're eager to work with states and try to unpack that. As I said, I think we have a number of authorities to support those kinds of models, but we got to hear that from, Medicaid is ultimately a joint state-federal program, and unless the state comes to us and says, we want to do X, again, going back to the last question, there's very little that we can mandate down, or that we want to, because it would never get executed well. We want to work with states, and especially here where there's such a great argument to be made for triple aim here. So appreciate the question.
Thank you.
Dr. Chow, Dennis Myers, nurse practitioner, certified with the American Academy and board certified in family practice, and I practice in Kentucky and Indiana and have a significant HIV and family practice number of clients. I'd like to address the Ryan White leg of your discussion. If the Ryan White CARE Act continues to adhere to the payer of last resort clause, what good is it today? I recently quit a Part B and C Ryan White clinic because it became increasingly difficult and untenable for us to get comprehensive primary care services through the Ryan White funded clinic. We went backwards. Instead of a one-stop shop type clinic which we developed through the Ryan White CARE Act and CARE practices, we now had to fraction our care and concentrate strictly on providing HIV services only, when given the fact that HIV is now a chronic disease, we now need more primary care integrated services. So how can we expedite transitioning HIV primary care into primary care services today? I think that's what is sorely needed.
And I think that's exactly the right question that we should all be grappling with. And I think that's precisely the question that I'm saying we all need to engage with, both at the federal level and at the state and local level. I think the short answer is that it's going to depend It's going to depend on the state. It's going to depend on the locality. It's going to depend on what the services that are being offered and what the state has been offering before. That's the dodge. The more direct answer is that I think there are absolutely opportunities to think about how we redesign that one-stop shopping center. That's what we want, right? We want systems to be able to support comprehensive, integrated, patient-centered care. That's what we all want. Whether it's the Ryan White program or the Medicaid program, that's our goal. And I think that through Medicaid, forming a foundation and a basis of that fundamental, broad-range, comprehensive, and affordable benefits, which, frankly, folks never had before under Ryan White in some respects, and we all know that in terms of the gaps there. Forming that finally as the basis for our patients, and then thinking about, well, Ryan White has been doing a great job at some of this other stuff, even if it wasn't always a comprehensive package of benefits. It was doing a great job on some of these other services and other wraparound services and other things like that. How can we integrate these systems? And so in California, as I said, I think what we did was try to think about stepping back and saying, how can we build those and bake those into this proposal? And I think most of those, frankly, still came through the Medicaid money and funding stream because of the way that particular state was structured. And that's why I'm saying it's going to depend on every state. But that trying to incorporate the systems of care, trying to incorporate the lessons of Ryan White, working with our HRSA providers to say, here's what we do well, here's what the best systems are doing, and bake that into the proposal. So the specific solution is going to vary, but it's just so clear to me that this is an opportunity to actually move forward rather than seeing this as, but I will say there's a danger, certainly, and as we saw in California, if we don't stay on top of this, to have that more further fractionate and have that package of service dissolve, and I think that's the concern. I think that's right, we need to continue to follow that.
One other note, I work in an area where infectious disease doctors don't want to take care of HIV anymore because of the primary care issues, and primary care providers do not want to take care of HIV because of the complexity of it. Fortunately, I've been trained in both, and I've been able to integrate, since leaving the Ryan White Care Act, into my primary care practice 100% of my HIV clientele. But that's not feasible for all providers. So. Yeah. Hopefully, maybe through the American Academy, we can train more providers and people that can branch out and help these people. I don't know, but that's the dilemma I'm having in the area that I'm in.
Well, as a payer, I don't think it would be appropriate for us to say what that model of care should be. I think that's up to the professionals. But I do think that we should be holding folks accountable for the kinds of quality outcomes, both in primary care and HIV medicine, and how that unfolds for the system. In this idea of designing these systems is going to be up to the system to how to execute. I'm getting the time signal. Should we do rapid fire, and then I can maybe take all these three at once?
We can just the folks that are standing. And we'll have opportunities as we go to the next panel, but instead of adding to the line, if we could just, sorry, sir.
Should I take all four? I mean, how tight for time are we?
Oh, we're
Should I take
okay
all
for
four of
about
these
5 more minutes.
Okay.
So.
Go ahead.
Okay. I'm Anita Case. I work at an HIV clinic in South Carolina where we have a governor who's not going to expand Medicaid. My question is, we're very heavily funded by Ryan White program, and we have a medical home model of care for our HIV patients. What I would like to advocate for, or find out if there's an option for, is the enhanced Medicaid reimbursement rates that community health centers get through the 330 funding for Ryan White funded clinics that already have a medical home infrastructure in place after 20 years of funding, as a way of moving those clinics forward, especially if Ryan White funding is going to diminish with the Affordable Care Act, especially for states like mine.
So this is, and I would probably take a shot at this if it weren't for the fact that Dr. Hobson's going to be here later. I think that's specifically under their rules in terms of who gets to be and who doesn't get to be under the 330 funding lines. But as I understand, an FQHC is very clearly defined by statute. And they don't have a whole lot of wiggle room from even HRSA's ability. So it's about that statutory definition, including the community-based board. And you've all heard this before. But there are pathways to become an FQHC. But again, I think that's beyond my scope of knowledge to some degree. And once they tell us they're an FQHC, that's when we sort of say what the payment rate is, but with the PPS issues.
No chance for the Ryan White funded clinics.
As I said, I don't think that there's, I think that's entirely up to, well, number one, if you statutorily change things, obviously that's a different picture, but I think barring changes in statute, and I wouldn't count these days on so much change in statute.
Maybe I should clarify. We do see Medicaid patients, so we get paid by
No, I understand.
Medicaid for
I
the
understand.
non.
I understand. But in terms of the question is, can a Ryan White provider become an FQHC, essentially? And I think that's going to be basically a Ryan White provider can be a federally qualified health center, which is the HRSA definition for who gets the 330 grant money. And unless there's something that Dr. Hobson knows that I don't, it seems to me the answer is the way to become an FQHC is the same way everyone else becomes an FQHC. So there's no going to be, I don't think there's a specific pathway for a Ryan White provider besides just simply qualifying under the standard laws and regulations.
And we will have a senior person from HRSA later today, so save that question and ask it again when she's here. Sir.
Hi, Dr. Cha. My name is David Munar. I'm President, CEO of AIDS Foundation of Chicago. Thank you for acknowledging the problems with the waiver, the 1115 waiver in California, and something that we've been monitoring closely. And there's an opportunity for CMS to make sure that future waivers are implemented in a better way. Cook County in Illinois is applying for a waiver, and we need to make sure that as the state negotiates with CMS, that we carefully look at the network, adequacy of the network, that we look at integration with Ryan White, that we avoid the pitfalls of California. And it's the county-based waiver, so there, it could fall under the same trap if we're not really careful. And we're also looking very closely in Illinois around the health home option. And I'm glad you mentioned that. And I think it's really important to look at, and I'm glad you acknowledged the Ryan White systems. Ryan White, though it's limited by an administrative cap and low appropriations and challenges, in many examples, we're getting very close to the kind of integrated model that the health home aspires to. So I think there's a lot of opportunities there. And I would just offer two quick recommendations. One is there could be, or there ought to be, through the CMS Innovations Grant, an opportunity for Ryan White networks to apply for innovations money, and that would bring the HRSA world and local providers closer to their state counterparts on Medicaid. And there's the HIV Health Access Working Group, which is a big coalition of advocates, is requesting that CMS identify an official, high-level official, to work on ACA implementation, specifically around the needs of people with HIV. Another recommendation I would ask you to look at. So my question is, you talked a lot about Ryan White and HRSA, Ryan White and ACA coming together. Can you describe, I know your time is brief and I've taken up a lot of it, just specifically what CMS is doing to work more deliberately, intentionally with HRSA on Ryan White integration with the ACA?
As I said, I think I outlined a couple, both at the high level, sort of the Presidential Advisory Council on HIV and AIDS level, high-level discussions, which both myself and HRSA are at the table for that. Also reaching out on the individual waivers when they come down and make sure we're tapping in the expertise in terms of the program analysts in terms of their best knowledge about what's going on, because a lot of this is in the details. It can't be just platitudes about, yes, let's coordinate. It's got to be how we actually unpack this problem, work together. I frankly think the second is harder. We get a lot less buzz and a lot less sexy recognition for it. But I'm telling you that's going on now, and that's what I'm most pleased about, trying to see how this moves forward. I'm not saying we're going to get this right every time either. I think that's why I'm saying most important is not what we're doing at a national level, but what you all are doing at the local level, because no matter what happens, we will always ask, what are the comments from the local level? What are your stakeholders saying? And if those comments are in there, we will get those, and we will see those and be able to understand, oh, well, here's a problem that they've identified with the particulars of their system. You got to be involved in that level of that conversation. So even if we're not directly engaging in this type of forum, that's how you get involved. That's how we can figure out how to work this all together. And frankly, a lot of these states want to do this right as well. And that's how they can learn about how they do this well. And I think, California was an experience where I think everyone had the best intentions. And I think it was a situation where, as it unfolded, we realized situations and things we should have done that we're trying to now apply moving forward. So I have no magic bullet. I'm not going to sit here and say, here's the magic formula. What I can tell you is that we're trying to get together both at the high levels, the medium levels, and every level to try and think about how this works. But we need you all. We need you guys to be at the local levels, weighing in with those waivers going forward or those proposals going forward, so that when we ask, or even so that they know what they should be doing better, so that we can all make sure this works out for the folks that you serve.
Something like the Innovations Grant would help bring some of those local providers to the table.
I think the SIM is something to take a look at, the State Innovations Model. It's a lot of money, and I think it's a potential real opportunity in terms of aligning the forces here across the various levers we have.
Actually, he really asked the same question that I was going to ask. I mean, fundamentally, I work in a community health center in Tucson, Arizona, do Ryan White Care. We're funded through Ryan White. And one of my fantasies is, well, what happens when 2014 comes along and all of my patients move to Medicaid or some other form of insurance? And truthfully, we have a very comprehensive system. I have a psychiatrist on site. I have behavioral health counselors on site, adherence counseling, all these things. I think I have a fabulous program. And I'm just not sure, and I can't in my dreams figure out how we're going to maintain that in the future where we're under Medicaid or insurance funding alone. And so I guess my question and my hope is, and as you said, I really hope you guys, CMS, are working really hard with the folks at HRSA HAB to figure out how we're going to continue to do this. And again, that's really, someone already asked my question, so
Yeah.
sure. Thank you.
And I think it's going to be incumbent upon all of us to try and make sure we get this right every time. And I think that's a great opportunity for me to just close with a few comments. But, I think that when I think about 2014 and when I think about the expansion, and when I think about the potential for patients to have actual coverage, an actual insurance card, as much as Ryan White has been just such an incredibly invaluable program and has done so well in certain areas, this is nothing less than a major, huge step forward. And I think everyone in the room knows that. I think we've all hit, as much as we love Ryan White, we've all hit those bars. And I think that that's fair to say, that it's constrained by the fact that it's a discretionary program with certain parameters. Transition to Medicaid takes those problems away, a lot of those problems away. So we are in a new world where we can build upon that. But, and so that's a real step forward in terms of offering patients comprehensive, affordable benefits. The second challenge for us is to ensure that we capture the best of what Ryan White is doing now. And whether that's funded by Medicaid under one of these authorities that I mentioned, medical home, integrated care model, state innovations model, whatever, whether it's one of those or whether it's some way to integrate Ryan White and the Medicaid funding together, I think we still have to unpack that box in terms of how that moves forward. But this seems like much more of an opportunity than it is something that is a negative. But the only dangers are that we need to work together and coordinate better. And that's never easy. And so, again, I think all I can do is offer our word that we're going to try and do our best to work hard at this. But we need you all there as well. So I appreciate the opportunity to talk with you all. Please spread the word about what's going on here, and if there are other forums, other ideas you have for us to continue to think about this, broader stakeholder calls, whatever. I think this is a message that needs to get out there, and we're committed to try and engaging that conversation and listening to what we need to be thinking about differently from all these experiences. So I want to thank you for your time here, and thank you for the opportunity to address you all. And I'll be able to stay for a little bit while longer, so I'm interested for the next panel and some of their thoughts as well. Thank you.